we're going to talk about hypertrophic cardiomyopathy and athletes and how to distinguish this. So we're sort of talking about the difference between a thick heart and whether or not this is physiologic change or whether or not this is a pathologic change. So if you remind yourself of the cardiac adaptations you often see with exercise, we think about these primarily as electrical or structural. So they're either going to affect the electrocardiogram or they're going to affect the echocardiogram, and many pieces go into this. Their age, their sex, body size, ethnicity, and what kind of sport they play all have impact in whether or not this is a physiologic athletic change or is this a pathologic finding. Now, the athlete evaluation is not a single test. No single test will be able to evaluate them and get you to that answer. You have to understand their history, what sort of sport they play, how long they've been playing that sport. Is this an endurance sport or is this a strength athlete? And then, yes, a comprehensive physical exam and an electrocardiogram are the primary ways we assess them to get things started. But I'm going to suggest to you that starting with an ECG is the easiest first step to take. So if you remind yourself that HCM ECGs are 90% abnormal. So if you're just find an abnormal ECG like the ones I'm showing here, the one at the top has Q waves that are most consistent with hypertrophic cardiomyopathy, or lateral T waves in V4, V5, and V6. This is a pathologic ECG and hypertrophic cardiomyopathy until proven otherwise. Athletes shouldn't have this ECG. Now, you may have LVH or increased hypertrophy, and you may have mild T-wave inversions in V1, V2, and V3, but there's a clear distinction between an athlete ECG and a pathologic change with hypertrophic cardiomyopathy, and starting with the simplest, cheapest test may help you decide what to do next. Because if you look at the data on this, if you follow them over time, they have a very high likelihood to develop hypertrophic cardiomyopathy or any type of cardiomyopathy, specifically with T-wave inversions. So when you see an ECG, you should be comprehensive. Transthoracic echo, cardiac MRI, and family screening or follow-up are going to be important ways you sort this out. Is this pathologic or is this physiologic? So there's some data on this. This is from Schnell many years ago, just about a decade, looking at T-wave inversions and how they evaluated this group. And they found that in almost half of them with T-wave inversions, there was a cardiomyopathy. Echo helped identify half, more with MRI. Exercise testing, not very helpful. Holter monitor, not very helpful. And then follow-up imaging. So over half, almost half of T-wave inversions will develop a cardiomyopathy over the next 8 to 10 years. Most of that will be identified by echo and cardiac MRI, almost 90%, and then follow-up. If you find normal findings with an ECG like that, it may not have developed yet HCM, but following them is going to be critical over time. So upfront imaging to sort it out, but if normal, the suspicions should still remain high. So here's an example of a young athlete I saw. Initially, family history of hypertrophic cardiomyopathy, gene negative, but look at the ECG on evaluation. Now, her first cardiac MRI, not a lot of increased wall thickness. A few years later, it was a little bit thicker, now 15 millimeters. With that ECG, this is diagnostic, but by the time she was 18, there was nothing subtle about it. 23 millimeters, she clearly has hypertrophic cardiomyopathy. So MRI and follow-up were the way we identified this young person for hypertrophic cardiomyopathy. So the ECG is a critical first step. But then it's multimodality imaging. Think about rest imaging with an echo, an MRI, or even CT in some scenarios, but then stress imaging on top of that. So both resting and stress imaging with echo or CPET or stress CMR will be helpful to distinguish this group. Because much like we saw with the electrocardiogram, the ventricle changes in the same way. So you get hypertrophy with or without dilatation. So you can have eccentric hypertrophy, you can have concentric hypertrophy, and they will either have a normal chamber or in most scenarios, they'll have a dilated ventricle that goes with it. So echo does most of the work, right? It's the diagnostic workhorse when we evaluate patients with HCM as well as athletes, and you're looking for that cutoff of less than 15 millimeters. So anything over 15 millimeters is pathologic until proven otherwise. But go a little deeper, not just the wall thickness, look at the chamber size. So we'd expect a normal sized ventricle and in more than half a dilated ventricle to be consistent with physiologic hypertrophy associated with an athlete. A smaller ventricle with a wall thickness of 14 or 15 millimeters is probably pathologic and should continue to be followed over time. Now, the sport matters as well. So this is one of the earlier studies from Polici in the 90s, looking at 600 elite athletes, both men and women, over the early 90s period. And you can see that in the endurance athletes, we often don't see hypertrophy. So although abnormal at 11 or 12 millimeters, very few of them at 13 or 14 millimeters. We saw the same thing in U.S. soccer athletes early in 2021. You can see that they were about a third in women and almost more than 40% in men were excessively thick. They were 11 or 12 millimeters beyond what the American Society of Echo considers normal. But very few of them approached that 15 millimeter thick walls. But men clearly had thicker hearts compared to women. So if you see a ventricle that may be an athlete that is 14 or 15 millimeters thick, it's pathologic. And in women, anything over 12 millimeters has a high suspicion that this is a pathologic ventricle. The race matters. This is a group from Singapore. There's not a lot of data on Asian athletes. So if you're looking for a research project, I met with a young person earlier today, and we talked about evaluating this and publishing this sort of data. You can see that a similar phenomenon occurs. In men, they're thicker compared to women, but very rarely do they get beyond 12 or 13 millimeters in this group of athletes. So not only does the sport matter, but the race does as well. If you look at black athletes, both men and women, the same story is true. Women typically don't have wall thickness above 11 or 12 millimeters, and even in black men, depending on the sport, these were endurance athletes, anything up to 13 millimeters can be considered physiologic, but beyond that, it's pathologic. Now, think about the difference, though, between the NFL athletes and the NBA athletes compared to the athletes we just talked about. These are much bigger individuals. In the NBA, approaching 7 feet tall, of course. And in the NFL, it's not uncommon to find a 300-pound lineman. So in this group, the story is different. So the sport matters. Almost 10% will have wall thickness over 13 millimeters in the NFL, and we saw the same phenomenon in the NBA. So not only does the sex matter, the race matters, but so does the sport. So when you evaluate somebody, it's more than just is the wall thickness thick or not, it's what did they do to attain that thickness. So using cutoff values for thickness is important. Anything over 15 millimeters is pathologic, and then under 15 millimeters, it matters what we're talking about. Are these young athletes? Are these older athletes? Are they men and women? And what sport do they play? So the measurement wall thickness is critical. So this is the same athlete that was measured 2 different times. They were initially referred to me for the one on the left side that measured 1.6 or 16 millimeters. That's pathologic. But look at the measurement. They measured it wrong. They included onto the RV structures, the moderator band or the RV crista supraventricularis, they over-measured in this young black athlete and gave him a diagnosis he didn't have. So the measurement accuracy is critical. And this is a study from 2021 showing those areas where onto the RV side, on the moderator band, into the LV cord, and at the apex next to the lungs are the typical areas where echo struggles, and utilizing MRI will be critical. So first with the echo, you're going to freeze frame. You're going to look at the wall thickness in both the long axis and the short axis. And then I'm going to suggest that you advance slowly, freezing through, making sure that you avoid the moderator band and correctly measure rather than over measure that wall thickness so that we can get an accurate, so that we don't overcall somebody with hypertrophic cardiomyopathy and that we get the measurement correct. Now, the apex is often an area where echo struggles. Next to the lungs, these are difficult to identify. Hopefully you can see that's clearly apical hypertrophic cardiomyopathy. Contrast can usually help define the wall thickness. But what if it looks like this one, where there's increased wall thickness at the apex, but not much different than the base? So if you compare that relative wall thickness, where we would normally expect the ventricle to get thinner as you get to the apex, this one stays about the same. So as we think about changes to the guidelines, we have to better define what that wall thickness looks like. This is data from Rebecca Hughes reminding us that when you go from the base to the apex in healthy volunteers, it should get thinner. But in apical HCM, it often gets thicker, and in some scenarios, it just stays the same. So relative wall thickness is a new way to start thinking about apical hypertrophic cardiomyopathy. So this is important specifically in women. So we know that we underdiagnose hypertrophic cardiomyopathy in women, and as a result of that, they have worse outcomes in virtually every category. More symptoms, later diagnosis, and worse comorbidities associated with hypertrophic cardiomyopathy. So an opportunity to better make that diagnosis with using relative wall thickness. Now you can look for supportive findings. These are multiple papillary muscles and apical displacement. Although not diagnostic of hypertrophic cardiomyopathy, they are certainly suggestive of hypertrophic cardiomyopathy. And crypts, what I'm showing you here, this big arrow here, myocardial crypts, again, not specific for HCM, but very suspicious for the development of HCM, a higher likelihood of gene positivity in this group, and very unusual in the athlete. So when you see this, a higher sense for suspicion for hypertrophic cardiomyopathy. Diastolic dysfunction in the athlete is generally normal. In fact, in most scenarios, it's supranormal. So in the endurance athlete, the runners, the cyclists, the swimmers expect to find medial E primes of 13, 15, and even 18. In strength athletes, like football players or rowers, you actually might see a little bit of a lower degree of thickness of diastolic function, but in general, still normal diastology. So that helps you separate that from hypertrophic cardiomyopathy. This is now an older study from Sharif Negwe, over a decade old, looking at the difference between controls, gene carriers, and then overtly positive HCM cases. In this scenario, diastolic dysfunction is much more common. So if you see an athlete with diastolic dysfunction, this is likely hypertrophic cardiomyopathy compared to the athlete where you'd expect it to be normal. Strain imaging the same way. You should expect to see normal strain imaging in athletes compared to that typical septal dysfunction in hypertrophic cardiomyopathy or in apical HCM where there's clearly a reduction in the apex. The quote, blueberry on top, seeing the differences between the apex towards the base. So normal GLS is hard to define, but I would submit to you anything under minus 15% is pathologic and requires active assessment for what might be wrong. But there's a caveat here. If you look at this data from Sheikh, over a decade old, 2015, he published this. Every criteria was evaluated in echo to separating HCM in athletes, and not a single test parameter was enough to distinguish HCM from exercise. So no single parameter will be able to distinguish this, and many of them have increased ventricles. So it's a myth that patients with HCM can't exercise because the majority of them, over 90%, will have a normal E prime velocity, will have a normal E prime ratio. So if you find thick heart with normal diastology or normal filling pressures, that does not exclude hypertrophic cardiomyopathy. So pathology confirms HCM, but absence of normal diastology won't make it athlete either way. Now, cardiac MRI plays a critical role in diagnosing HCM, whether it's morphology and function, but edema, fat, and late gadolinium assessment clearly separates this. Now, we talked about the problem areas for echocardiography. MRI shines in both underestimating and overestimating compared to echo. So it's much more diagnostic compared to echo using cardiac MRI. And it's the areas that you know echo struggles with. It's the apex of the ventricle, it's the interventricular septum and the posterior wall, the lateral wall, and in non-contiguous hypertrophy. These are all areas where echo struggles, but MRI can help you better define the true wall thickness related to HCM or the athlete. Now, scar tissue is very common in HCM. Depending on the study, as much as 70% of patients with HCM will have scar, which is why we can't use it as a single parameter for sudden death risk. It's the amount, not the presence, that matters with regards to sudden death risk. But in the athlete, you shouldn't find it. Under the age of 30, scar is very rare. In the athlete over the age of 35 or 40, you might find incidental fibrosis, what we often refer to as dots and spots, those small areas at the RV insertion or in the midventricular wall. These are commonly found in 40 to 60-year-old male endurance athletes, but under the age of 30 or 35, if you find scar, it is pathologic until proven otherwise. And what you're trying to find is a typical scar pattern of hypertrophic cardiomyopathy. Increased septal scar on the top or in the septal wall there. These are HCM even in the absence of severe hypertrophy. If you find scar burden in an area that's thick, this is hypertrophic cardiomyopathy and requires further assessment. Now, T1 mapping is somewhat of a newer technique, looking at either a native or a post-contrast imaging or ECV, and it can provide a robust marker for an abnormal substrate. So we often refer to cardiac MRI as a virtual biopsy of the heart. Now, more than ever, it looks into the myocardium itself, and the level of the T1 mapping and ECV in clinical practice can help you sort out between amyloid, hypertrophic cardiomyopathy, and even Fabry cardiomyopathy. And it can help you distinguish between those pathologic entities. So using cardiac MRI in those with thicker hearts is important, but it's also important in the athletes. This is a single study, although small, looking at 50 patients with HCM and 40 highly trained athletes, and the use of ECV specifically. So T1 map pre-contrast, T1 map post-contrast, calculating an ECV, and you can see that if a ECV value was under 22%, this was much more likely to be physiologic hypertrophy compared to pathologic hypertrophy. So just using ECV can help you look for whether or not this is HCM or athlete. Now, not perfect. There is some overlap, but in that gray zone area, this is a very valuable tool to distinguish between physiologic adaptation and pathologic. Now, we talked early on about stress testing. So this is an important way to sort through, folks. In athletes, we would typically like to see a higher level of VO2 max. If you have a lower VO2 max, this is often more likely to be hypertrophic cardiomyopathy. Most HCM VO2 levels are actually in the 18 to 22 mark. Now, T-wave normalization after exercise by most pediatric cardiologists are often thought to be helpful in distinguishing. But if you look at the data pre and post exercise, T1 normalization happens in almost 80% of those with T-wave inversions. But unfortunately, it happens in both athletes and in patients with hypertrophic cardiomyopathy. So its ability to distinguish between cardiomyopathy and athlete really isn't helpful. So if you exercise somebody and the T waves invert to normal, it may feel like this is a good thing, but it actually means nothing. So it doesn't really help you in distinguishing between HCM or not. And then finally, detraining is often something that people ask me about. And we know that there are findings that are abnormal on ECG for the athlete that if you detrain them and tell them to stop exercising, they will normalize. But in general, the data on this is very weak. Older data, this is strength athletes and this is endurance athletes. You can see one with 5 patients and one with 6. Not a lot of data to support detraining. So you don't really need detraining in the current era. Most of this can be sorted out using a good echo with Doppler, strain imaging, and cardiac MRI and a stress test. You don't really need to keep them out of training for 3 months to determine it. And by the way, the data doesn't support doing that anyway. So when you're distinguishing between athlete and the HCM, or the quote gray zone between the athlete and hypertrophic cardiomyopathy, the key is to build a case. Accumulate the findings in either pathologic or physiologic, and it's usually going to require more than one imaging assessment, and then include age, sex, sport, abnormal ECG or not, CMR for fibrosis, and the degree of hypertrophy with or without strain imaging. This is going to be the way we sort out between athlete and hypertrophic cardiomyopathy. Thank you for your attention.